le service d'ophtalmo qui est nouveau, dirigé par notre ami professeur Khamil El-Mehdi. Cette réunion, on va discuter le thème de la membrane amniotique, qui est très intéressant. C'est vrai qu'on peut se la procurer à partir de l'hôpital universitaire de Marrakech, mais parfois, on est dans l'urgence et l'obligation, et vu le transport, les moyens de transport, avoir une membrane à sécher qu'on peut utiliser, mais comment l'utiliser, c'est ce qu'on va voir lors de cette réunion. Et je remercie tous les participants et je laisse la parole maintenant au staff pour nous expliquer l'utilité, l'intérêt et comment utiliser cette membrane. Et ainsi, c'est le professeur Belmki qui va prendre la parole et lancer la discussion. Merci, professeur Khamili. À vous la parole.
Merci, mon général.
Bonjour tout le monde. Bonjour tout le monde. Je me présente. Je suis Dr Sharal Fatem Zahra, médecin coordinateur de la consultation du pôle consultation et exploration adulte au sein de l'hôpital universitaire international Mohammed VI. Monsieur le directeur médical, Dr Aziz Yahya, s'excuse de ne pas pouvoir être parmi nous ce jour. Et c'est avec un grand honneur que nous accueillons aujourd'hui notre première conférence en ophtalmologie sur un thème très intéressant qui est la greffe de la membrane amniotique déshydratée, organisée en collaboration avec l'association Young Ophthalmologist of Morocco, avec ISP Surgical et Supraclinic Academy, avec la participation des experts nationaux et internationaux. Je tiens à remercier vivement notre cher professeur et le directeur de spécialité en ophtalmologie, professeur Oubaz, professeur Oubaz, ainsi que nos chers professeurs seniors, professeur Benmeki, professeur assistant, professeur Khamaili, professeur Mohib et docteur Sarah Idman. J'espère que cette expérience aboutira à d'autres journées scientifiques en distanciel ou en présentiel si les conditions épidémiologiques le permettent. Sans trop tarder, je vous souhaite la bienvenue et je donne la parole au professeur Belmeki pour commencer notre journée. Merci.
Merci. Je prends la parole pour introduire le professeur Belmeki, qui est un de nos grands ophtalmologistes responsable de la spécialité à l'hôpital Cheikh Zayed et à l'université Aboul Qassis. Professeur Belmeki, à vous la parole. Merci.
Merci beaucoup, mon général. À mon tour de remercier professeur Khamaili et toute son équipe d'avoir bien voulu organiser cette réunion extrêmement importante sur un thème qui est extrêmement important, qui est celui de la membrane amniotique. Et c'est quelque chose, comme vous l'avez dit, mon général, qui a une grande importance en pratique clinique actuellement. Et donc, sans trop tarder, j'ai le plaisir d'annoncer notre ami professeur Ashraf Armia, qui est un consultant, un éminent consultant de la pathologie donc du segment antérieur, en particulier la cornée, la reconstruction de surface et la cataracte. Il est le fondateur de la clinique Ashraf Armia. Il est également le fondateur d'un programme de formation qui porte son nom. Il est le fondateur d'une société extrêmement importante et actuellement très active dans le domaine d'ophtalmologie, surtout avec ces temps du Covid, qui est GERSO, qui organise régulièrement plusieurs réunions chaque semaine. Il est également le fondateur du Collège international ou mondial de chirurgie réfractive. Il est dans le board du journal SRS et finalement, c'est un grand chercheur en matière d'ophtalmologie en Égypte. Nous souhaitons la bienvenue à notre ami Ashraf et nous l'écouterons avec beaucoup d'intérêt. Merci beaucoup, Sharab.
Okay, thank you so much for the invitation. I will. I'm happy to be among you all from Egypt, and maybe next time we are going to be live all together in Morocco. So I'm going to share my screen. Sorry for this. I'm going to talk in English, not in French. Forgive me for this. So my talk will going to be the history of AMT used in ophthalmology and its various applications. I'm going to talk about the history and what's in the future. These are my financial disclosure. So amniotic membrane or amnion is the innermost layer of the placenta and consists of a thick basement membrane and a vascular stromal matrix. The amniotic membrane transplantation has been used as a graft or as a dressing in different surgical subspecialties. And in the field of ophthalmology, it is used broadly to reconstruct the ocular surface after various procedures. And also all those indications make use of amniotic membrane ability to promote the healing. So if we want to talk about the future, we should talk about the history. So it's history, it's a live fetal membrane, which included both the amnion and the corneal, was first documented by Dr. Roth in 1940 for the use of conjunctival reconstruction. A very low success rate was reported. So during the same year, Brown used the rabbit plutonium as a temporary patch for the ocular surface burns which Sorcery later modified with the human amniotic membrane in 1946 and 1947. In 1995, Kim and al. Reintroduced the idea of amniotic membrane for ophthalmic use, which has since become increasingly popular. So this is the history starting from the skin 1893 till introduction of tissue glue with amniotic membrane in 2004. If we are going, I'm going to highlight how they started the amniotic membrane till we reach this era. So it's used for the treatment of cicatricial pemphigoid and Stevens-Johnson syndrome in 1996. Also at the pterygium in 1997 to treat the area when we remove the pterygium. Also for persistent epithelial effects and ulceration, Lee and Zing 1997. And also conjunctival surface reconstruction in 1997. And ocular surface reconstruction with patients with chemical and thermal burns in 1997. You are going to see we are using the amniotic membrane a lot of things in ophthalmology. Because the amniotic membrane is an anti-inflammatory and antimicrobial properties with a low immunogenicity that Hori and al. Published in 2006. The earliest evidence of low immunogenicity dates back to 1981 when Ackley in 19 demonstrated the lack of immunogenicity of the human amniotic membrane epithelial cells. In fact, these cells do not express the HLA-A, B, C, DR antigen, or the B2 microglobins on their surface. Also, they used the basement membrane is involved in the migration of the epithelial cells in 1986. And also the amniotic membrane prevent the apoptosis and promotes adhesion of various cells and helps maintain normal epithelial cells, which was published in 1992 and 2005. Also in 2000, they identified several angiogenic and anti-inflammatory properties for the amniotic membrane. And it noted that the cornea and the vitreous are avascular tissues, which is why the characteristic effect of amniotic membrane is an advantage. Very important to note that the storage of 4 months for the tissue bank offers sufficient time to plan and perform surgeries or clinical trials, as DUA in 1999 published. And also the long-term and short-term storage methods were previously reported, including freezing, drying, storage in media up to 28 days, and was published in 2007. And also they said that the AM patches are stored and preserved at temperature of below minus 140 degrees centigrade for 5 years, and this can happen. What is the mechanism of action? The mechanism of action is the basement membrane component of the amniotic membrane is similar in composition to the conjunctiva. So for this reason, the amniotic membrane augments support for epithelial cells and limbal stem cells, deficiency, and corneal transient amplifying cells. So furthermore, the stromal face of the amniotic membrane suppresses the myofibroblast differentiation of normal fibroblasts to produce the scar and the vascular formation. And this can assist in the healing of conjunctival reconstruction, epithelial defect, or stromal ulceration. If we looked in ophthalmology, we can use the amniotic membrane in pterygium, during pterygium excision, reconstruction of the conjunctiva and surface, limbal cell deficiency or persistent epithelial defects, corneal ulcer, ocular surface burns, and Dr. Harvey was going to talk about how he's going to use this in macular hole. So the advantage of amniotic membrane, it's a less pain as a donor site is not found, shorter surgical time, faster patient recovery, amenable to cover large defects. It saves the donor site for surgeries like the glaucoma, you preserve the conjunctiva, and it's better for cosmetic outcome. What is the role of amniotic membrane? It's a barrier, it's a substrate, a growth factor, it's a bandages for ulcers, inhibit inflammation, prevent evaporation, prevent recurrence, and allow stem cells to populate area. What is the future? As we all know, that one of the drawbacks of using the amniotic membrane in eye care is the inability for active ingredients of the amniotic membrane to persist on the eye without a membrane on the eye. So the membrane itself is obviously not vital unless replacing the conjunctiva. So therefore, access of these biologic in a drop form would allow for consistent treatment over time and better, more persistent outcomes in chronic disease such as dry eye and cicatricial disease. We are going to have it in a drops. The bio-tissue in developing a morsite amniotic membrane tissue, eye drop, in order to allow for easier and persistent treatment of ocular surface. There is another company of ocular science marketed drop. They term the amniotic membrane cytokine extract. And this drop, the eye drop, contains cytokines, growth factors, and anti-inflammatory molecules. As with all the biologics companies, the methods of extraction and sterilization is mandatory. There is a lack of prospective placebo-controlled studies with either these drops at this time. Regenerative Network International is marketing the human amniotic membrane drop for treatment of dry eye disease. And this drop has been found to contain stem cells, amniocytes, which have been proven to accelerate the wound healing in an animal model and thought to contain substance similar to amniotic membrane. However, studies looking at wound healing typically use donate the eye drops, the human eye drops, from genetic testing. And therefore, these drops used in these studies is harvested much earlier in gestation than the eye drops being used in Biogeneration Network International. So, what's the conclusion? Although the history of use of this tissue showed modest success in early 1990s, newer methods of storage have made the membrane more available and expanded its use. And amniotic membrane medicine is expanding in many specialty areas, including the ocular applications, and the future of this tissue in the eye care lies in the development of a drop form containing the key biologic to treat patients more easily and persistently over time. Thank you so much for listening.
Wow. Great. Thank you, doctor.
Thank you. So I will introduce my presentation. All my slides will be in English, but I will talk in French to be more comfortable for me. So, la membrane amniotique déshydratée pour la première fois au Maroc. Donc, je déclare que je n'ai pas aucun conflit d'intérêt pour cette présentation. La membrane amniotique est la couche interne qui recouvre le fœtus, qui est composée de trois couches, l'épithélium, une membrane basale et un stroma. Pour l'épithélium, il est doté d'une action anti-inflammatoire avec, au niveau de la membrane basale, des collagènes de type 3 et 4, ainsi d'un stroma qui est riche en collagène type 1, 3, collagène 4 et protéoglycane. Concernant la composition de la membrane amniotique, il y a déjà un épithélium qui est cubique mononucléaire, qui est activement, physiologiquement active, avec des facteurs de croissance, des cytokines, avec un facteur de croissance épidermale et les kératocytes facteurs de croissance. Une membrane basale qui est riche en collagène, qui est similaire au collagène de la conjonctive et de la cornée, et au niveau du stroma, qui est avasculaire, riche en collagène et en cellules. Concernant les mécanismes d'action, ça va promouvoir l'épithélisation cornéenne à travers les facteurs de croissance, ça va inhiber la vascularisation à travers l'endostatine et d'autres facteurs, une action antibactérienne et une action anti-inflammatoire à travers les facteurs de croissance. Elle va jouer aussi un rôle de bondage biologique qui va réduire la peine et qui va être un réservoir des facteurs de croissance. Une membrane basale qui va faciliter la migration et l'adhésion des cellules. On parlait du mécanisme d'action de la membrane amniotique qui va promouvoir l'épithélisation cornéenne, qui va inhiber la vascularisation à travers l'endostastine, une action antibactérienne et une action anti-inflammatoire. Elle va jouer aussi un rôle de bondage biologique et grâce à sa membrane basale, ça va faciliter la migration et l'adhésion des cellules épithéliales. Et il y a aussi une action non immunogénique vu son absence en HLA. Donc, l'histoire de la membrane amniotique date de 1910 à l'hôpital de Hopkins en Angleterre par Davis, qui a fait la première greffe de membrane amniotique en dermatologie. En 1940, c'est Roth qui a fait la première chirurgie plastique de réparation conjonctivale par une membrane amniotique. Donc, le choix qu'on doit faire, est-ce que on va utiliser la phase épithéliale ou la phase stromale? Donc, si on cherche un but anti-inflammatoire, antifibrotique avec un anti-angiogénique propriété, dans ce cas, on va utiliser l'épithélium side-down en rapport avec la cornée. Et si on veut fermer un trou au niveau de la cornée, pour repérer un trou, dans ce cas, c'est le stroma side-down. Donc, on peut dire que la membrane amniotique est un vrai couteau suisse qui est utilisé dans plusieurs indications, ce qui va être aussi détaillé par Dr. Harvey par la suite. Tout d'abord, dans les syndromes secs, les ulcères neurotrophiques, les défects épithéliaux, dans les seins blépharons, après une chirurgie réfractive en PKR, après un cross-linking, dans les conjonctivocalasis, dans la chirurgie du ptérygium, dans les tumeurs ou les tumeurs conjonctivales et aussi dans la chirurgie traumaculaire. Donc, comment avoir une membrane amniotique? Soit elle doit être fraîche, elle a des avantages parce qu'elle va garder toutes ses qualités, Par contre, parmi ces inconvénients, il y a le risque d'infection, de transmission d'infection et surtout le gaspillage du tissulaire pour quelques centimètres. On peut aussi avoir une membrane amniotique cryoconservée, et cela soit dans les yeux, dans les banques des yeux, notamment qu'on a au Maroc, et d'autres produits commercialisés, notamment Procera et l'Amniotic Graft. Ou bien une membrane amniotique déshydratée, notamment l'Amniotic, qui est commercialisé par ESP Surgical et présenté au Maroc par Supraclinic, l'ambiodisque, la RIL, Omnigène ou l'opticite. Donc, si on est mené à faire un choix entre une membrane amniotique déshydratée et une membrane amniotique cryoconservée, le choix va être rapidement fait. Donc, pour la membrane amniotique déshydratée, côté sécurité, c'est la même chose pour les deux. Côté conservation, la membrane amniotique déshydratée, elle est conservée dans une température ambiante pendant 3 ans. Par contre, la cryoconservée, elle nécessite une zone de congélation. Les sutures, pour la membrane amniotique déshydratée, on n'a pas besoin de faire des sutures par rapport à la cryoconservée et ça peut même être fait au niveau de la consultation. Donc, le temps pour faire la membrane amniotique ou bien pour greffer une membrane amniotique déshydratée. Donc, les dernières recommandations qui datent d'octobre 2021 qui suggèrent faire la membrane amniotique déshydratée comme un patch au niveau de la surface oculaire dans les débuts de la maladie. Concernant le Maroc dispose heureusement et malheureusement qu'une seule banque des yeux qui est à Marrakech, qui a été inaugurée en 2011, mais malheureusement, ça ne peut pas couvrir tout le royaume du Maroc. Donc, parce qu'il est sollicité et demandé par tous les ophtalmos du Maroc. Donc, comment avoir une membrane amniotique déshydratée, ou bien, pardon, comment on peut avoir une membrane amniotique au Maroc? Il faut avoir une glacière, et il faut se diriger vers Marrakech pour s'en procurer. Finalement, la membrane amniotique déshydratée est finalement au Maroc. C'est l'Amniotic qui est commercialisé par ESP Surgical et Supraclinic in Morocco, qui est dans le marché mondial depuis 2014, native l'amnion humain et qui préserve toute son architecture et qui maintient la présence des cytokines et des facteurs de croissance. Pourquoi l'Amniotic? Elle est conservée dans une température ambiante pendant 3 ans, ne nécessite pas de suture, avec une épaisseur entre 40 et 60 microns sans le LEPAC, ne nécessite pas de fixation palpébrale comme lors de la Procera. Il suffit de faire un bandage par une conchise de contact et même à la consultation. L'Amniotic est disposée en plusieurs packs, plusieurs patchs. Donc, le box de la membrane amniotique est composé d'une membrane amniotique, des microsponges, un forceps et une lentille de contact. Donc, comment on peut s'orienter pour greffer cette membrane amniotique? Pour la membrane en patch sous forme de cercle, on va suivre l'orientation des aiguilles-montres, la petite partie qui doit être suivie de la grande partie dans le sens exact des aiguilles d'une montre. Comme ça, la face épithéliale va être en bas, qui va être posée au niveau de la cornée. Pour l'autre patch qui est de 3 sur 3 cm, qui est orienté par un petit trou au niveau de cette membrane. Et pour cela, j'ai trouvé une astuce, c'est qu'on va dire que c'est DR orientation comme docteur. D pour distal right, donc le bout va être distal et à droite. Et deuxième astuce, c'est que down va être le stroma. Donc distal right and down stroma. La greffe de membrane amniotique d'Amniotic, ça commence par une mise en place d'un blépharostat, une désépitalisation périphérique de l'épithélium, une mise en place de l'Amniotic qui est dotée d'un trou pour garder une visibilité commune pour le patient. On va faire un bandage par une lentille thérapeutique et l'ablation de la blépharostat. Il faut juste faire attention à ne pas toucher la lentille. Donc, ici, un cas de kératopathie bulleuse avec une prise de fluo, un défect épithélial large et des buées sous-épithéliales à l'OCT. Donc, on a opté pour une membrane amniotique déshydratée amniothèque. Là, c'est le jour même lors de l'amniothèque. Avec, on voit ici la membrane amniotique, l'amniothèque qui recouvre la partie épithéliale et la lentille de contact au-dessus. Donc, 48 heures, on remarque déjà qu'il y a une diminution de la rougeur l'hyperémie conjonctivale et même un soulagement côté douleur pour la patiente. Pour un large épithélial défect, il y a aussi une méthode de 2 en 1. On va poser la membrane amniotique directement sur la lentille et on va la poser aussi directement au niveau de l'œil du patient, comme on pose une lentille de contact simple. Donc, un patient qui était opéré opéré, implanté d'un artisan. Donc, il présentait un large défect épithélial une semaine après l'amniothèque. Donc, j'étais aussi inspiré pour la chirurgie de ptérygion avec amniothèque par Dr Harvey, qui va la détailler par la suite. Donc, là, c'est la membrane amniotique stroma down. Une fois on l'a mis au niveau de la conjonctive, il est réhydraté et ça va prendre place. Et aussi, il ne faut pas oublier à recouvrir la partie du défect épithélial qui va soulager vraiment la douleur pour la patiente. Donc, on a mis 2 points de rapprochement et la pose de la lentille à la fin de l'intervention. Donc, là, le ptérygion avant la chirurgie et deuxième photo, c'est une semaine après. Donc, je vous remercie et je donne la parole à professeur Mohib.
Good morning, good afternoon, and good evening, because I think we're covering several time zones.
Yes.
And thank you, Jay, for having me speak about in-office application of dehydrated amniotic membrane. By the way, the meeting starts at 3 o'clock in Morocco for the Young Ophthalmologist. That has some symbolic significance, which I'll get to you, explain to you later. So in our experience, we've used it in the office for more than 20, 25 years. The in-office application is done by both ophthalmologists and optometrists. In fact, the ophthalmologists, as surgeons, use it more in the operating room, and the optometrists do it more in our office. And as the speakers have spoken to before, Dr. Mehdi and Dr. Armini, we use them. The amniotic membrane is especially beneficial for persistent corneal defects, such as abrasions, recurrent erosions, severe dry eye, infectious or sterile ulcers, chemical thermal burns, limbal cells diseases, neurotrophic keratopathy, really any ulceration, and also post-op care as well. It's pretty simple and effective. And if you think it through, you basically need anesthetic topical drops, a lid speculum, preferably non-tooth forceps. It's optional to have a cotton tip applicator or Wexel sponge. Of course, you need a dry amniotic membrane, which is packaged. And you want to follow up with some antibiotic topical drops. And also you want to apply a soft contact lens, preferably a large diameter. Here's Dr. Jeraponi's Supo Kawadi's video, and I'll show you that. By the way, this is done on the table, and we usually do it sitting up in the sit lap or at the sit lap in the sitting up position. Again, you can do this in a sitting up position or at the sit lap if you have a good assistant. I'll go over the orientation, but the big tab is at 3 o'clock and the small tab is at 12 o'clock for epithelial side down. This video is done in Thailand. I'm not sure where the music comes from. There you see the membrane and the contact lens covering the defect. So a couple of important points I want to emphasize, and if you can remember 3 things today, is it's important to know that once you lay down the amniotic membrane, it immediately adheres to the cornea. So it's pretty difficult to remove once you apply for the first time. The dehydrated tissue is extremely thin and lightweight. So again, your best chance is your first application. You don't want to be moving it after you put it down initially. And you also want to place the amniotic membrane over the center of the defect. And then you want to smooth the graft into the ocular surface with your applicators as best as possible to remove any wrinkles. But if you do have wrinkles, it's probably okay. You can also fold or apply multiple amniotic membranes on top of each other. And for the orientation, just remember, the large tab is at 3 o'clock. The small tab is at 1 o'clock, sorry, 12 o'clock. And that's epithelial side down to promote the reepithelialization. So remember, the meeting in Morocco started today at 3 o'clock. You want the big tab at 3 o'clock for epithelial side down. That's a good way to remember it. And then, of course, you want to follow with the contact lens application. And as opposed to patching, you do want to use a bandaged contact lens, preferably large diameter. It's important for this because patients are comfortable, they can ambulate and return to work. And people will notice that the amniotic membrane dissipates differently in different patients. So the contact lens is another factor that keeps things comfortable. Is also the contact lens serves as a vehicle for applying therapeutic drops. And both the amniotic membrane and the contact lens will promote healing and reepithelialization and hopefully reduce some scar formation. If you have any questions, please email me. I'm welcome to answering any of your questions. Thank you very much.
Thank you, Dr. Ko. And I just want to say I've known Dr. Ko for many years, in all my years when I was in Boston. I've known him for at least 20 years. But one thing I'll brag about Dr. Ko, he's the only ophthalmologist I ever met that can do phaco both right and left-handed. So I just wanted to say that. I hope I didn't embarrass you, Dr. Ko, but that's, in all my years, that's pretty amazing thing. Thank you.
Thank you.
All right.
It gets good when my hand gets tired. I can switch over.
Thank you, Dr. Ko.
Thank you. Can you give me back on? Okay.
Thank you, Dr. Wilson, for your great presentation.
It's a great pleasure for me to be here to share our experiences on the ever-widening applications of dehydrated amniotic membranes. And I would like to thank the previous speakers before me who talked about the basics of amniotic membrane transplants, including the techniques. Thank you, Dr. Ko. And for this talk, I'll be focusing mainly on our surgical videos as well as outcomes. So I started using cryopreserved amniotic membranes 25 years ago. And pretty soon, we found out that it's very difficult to obtain this cryopreserved membrane, and that the techniques generally required suturing, which took a long time and left the patients uncomfortable after cryopreserved amniotic membrane transplantation. So about 10 years ago, I met Jay, and he
Excuse me
introduced
for
us.
inter.
Okay, so rewind. So I'm going to focus more in this talk about the practical applications of dehydrated amniotic membrane. And as Dr. Ko mentioned, the main advantages are it's very accessible. It's very easy to transport. You could put it basically on a car and drive through the desert to another site and use the amniotic membrane right off the bat. And as Dr. Ko showed, you can apply it without the need for suturing, which makes it very convenient and very comfortable as well for patients. So we've been using the dehydrated amniotic membranes for almost 10 years now, mostly for patients with ocular surface disease, but later we'll talk about some other applications. So this is the usual technique we do. In many cases, we'll do a little bit of a keratectomy. You can use a blade 15, or you can use a Wexel. And the reason for doing this is that it increases the adhesiveness or the stickiness of the corneal surface, and the amniotic membrane holds on a little better. Okay, so if you do have a epithelial defect, then you can just apply the amniotic membrane directly. And here we show you our technique using a dual blade speculum. And as Dr. Ko mentioned, it's very important to put it right in the center, and be careful to when you apply the amniotic membrane, that it covers the whole surface and the contact lens. And the most careful thing is removal of the dual blade lid speculum in a way that you don't displace the contact lens and amniotic membrane. So you do it carefully, and then you roll up one side, and then you roll up the other side. So that's probably the hardest part of the whole process, removing the dual blade lid speculum. And for those of you who have difficulty removing the lid speculum, you can even do it without the lid speculum, without lid retractors. So if you have a cooperative patient, you put your topical anesthesia, you can hold the eyelids open with your bare hands, and then apply the amniotic membrane. Then you apply the contact lens. Here you see the amniotic C with a hole in the middle, and you align that with the pupil so that the visual axis is not covered by the translucent dehydrated membrane, and the patients they attain comfort from the amniotic membrane implantation, and because the visual axis is clear, they can actually go to work the next day with relief of their ocular surface disease. And these are just some of the many indications for which we have used the amniotic membrane. And we'll show you some sample cases. Here's a patient. He's a construction worker who splashed acid on his cornea. So after cleaning and washing it out, you can see this huge defect, almost 100% of the cornea. And we applied the amniotic membrane, and the patient was able to get his vision back and go back to work very quickly. Here's an elderly female with a recurrent filamentary keratitis. Despite removing the filaments and giving anti-inflammatory medicines and lubrication, it still kept coming back. So what we did in the end that solved her problem was we removed the epithelium, Wexel keratectomy, applied the dehydrated amniotic membrane, and held it in place with the bandage contact lens. And a month after, removed everything. You can see very nice cornea, problem solved. Here's a patient post-corneal transplant, and she developed this epithelial defect, which made her uncomfortable. So we applied the amniotic membrane, bandage contact lens, which helped the defect at least mostly resolve, and the patient got her vision back and got back some comfort. This is a patient who's an office worker spending 12 hours in front of a computer screen. This causes a lot of dry eye. You can see the florid superficial punctate lesions. And she was unable to work until we applied the dehydrated amniotic membrane and the contact lens. For these cases, it's important also to emphasize changing their lifestyle. Maybe they still have to work, but at least avoid exposure, go to sleep early, and intensive lubrication. And this patient actually, a year later, it recurred, and we applied the amniotic membrane again, and she was able to continue working. This patient had no more vision. He had pseudophakic bullous keratopathy, didn't want any corneal transplant, but once in a while, you have this epithelial defect that makes it uncomfortable. So you can apply the amniotic membrane and contact lens, and while you can't restore the vision, at least you can make the patients comfortable. And we like to use it a lot, especially for young females with recurrent corneal erosion. You see this one where the erosion here on the left actually impinges on the visual axis. So there was some decrease in visual acuity. And we tried conservative management first with lubrications, but it kept coming back. Eventually, the patient agreed to amniotic membrane transplantation with bandage contact lens, and this resolved their problem. And we haven't seen this patient for a long time. But this shows you also, this is a wavefront aberrometry image. You can see here on the left with the recurrent corneal erosion lesions, there was a lot of irregular astigmatism on the cornea, accounting for her poor visual acuity. And after treatment with the amniotic membrane and removal of the complex a few weeks later, the patient's vision improved to 20/20. And you can see that the corneal irregularities have greatly diminished. This is a similar case. She loves wearing contact lenses, but this led to a lot of ocular surface abnormalities and recurrent erosion and non-healing defects. After the amniotic membrane, she was able to resolve her problem, get back her smooth cornea, and go back to work. And we told this patient to stop wearing contact lens. And here, similarly, you can see a lot of irregular astigmatism on the wavefront aberrometer. And after amniotic membrane treatment and lubrication and removal of the amniotic membrane contact lens, after a few weeks, you can see a return to normal of the patient's corneal astigmatism. I think in the Middle East, just like here in the Philippines, we have a lot of sun. And because of this, we see a lot of patients with pterygium. And this is one of our main indications actually for using dehydrated amniotic membranes. I think most surgeons have largely abandoned doing the bare sclera technique, just scraping it off and letting it heal, because this is associated with a very high recurrence rate. So most surgeons would either put in a conjunctival autograft, or you can use amniotic membrane transplants, as well as a few adjunctive options like mitomycin C, suturing, and use of fibrin glue. So this is just a recap of our 50 eyes that underwent pterygium surgery with amniotic membrane transplantation. 40 were primary pterygium removal and 10 were recurrent. And our technique is to excise the bare sclera, apply mitomycin C for 2 minutes, wash this off, and then we apply the amniotic membrane over the bare sclera, and making sure that some of the amniotic membrane would cover the corneal epithelial defect, so that a defect on the corneal side after scraping off the pterygium. We then apply wing-type sutures to hold the conjunctival or scleral portion of the amniotic membrane in place, and then bandage contact lens to hold the corneal portion of the amniotic membrane in place. And I'll show you a video of this technique. So here the pterygium has been removed, so we cut the amniotic membrane to a size where you can cover the bare sclera as well as the corneal epithelial defect. So the scleral side, we basically suture the conjunctiva to hold it in place, and you can put 2 sutures close to the limbal area. And for the corneal side of the amniotic membrane, we just hold it in place with the bandage contact lens. And you can see here that the bandage contact lens even covers the two sutures. And by doing this, the patient doesn't feel the raw edges of the cornea or the bare sclera, and they're very comfortable. And usually the next day they can already go to work. So in our series of 50 eyes, in almost all of them except one, the contact lens stayed in place. One patient actually washed it away while taking a shower. And all of them had complete corneal reepithelialization. We didn't see any adverse events. The patients are very comfortable after the surgery. And over the 8 years that we've been doing it, we had to repeat the pterygium removal in only 3 patients. So I think this is a very low recurrence rate. One good thing about this technique is we don't have to harvest the conjunctiva, and you don't create the second wound, and you don't make your glaucoma colleagues angry because you've already messed up the conjunctiva when they do their trabeculectomy years later. We also believe that it leads to a lower recurrence rate, even if you're not using a conjunctival autograft, because the amniotic membrane has some inflammatory mediators that lessen inflammation and the risk for recurrence. And we like to do this technique because, when you do conjunctival autograft, it actually takes more time to harvest the autograft, transfer it, and then suture it in place if you're using sutures. With the amniotic membrane, you just have the nurse open the pack and then cut the amniotic membrane to the appropriate size, and then you place it there, and then you can use either sutures or glue to hold it in place. But definitely you save time by not having to harvest a conjunctival autograft. Some of our colleagues in the glaucoma field have also reported on amniotic membranes being used to cover glaucoma drainage devices, as well as for revising blebs. I'm not a glaucoma person, but I'd like to share this video, which was shared with us by Dr. Robert Noecker in Boston. So you can see here a amniotic membrane being used to cover this AMED valve tube. Okay, so this is the Amniotic G, which is thicker. It's about 150 microns, triple the thickness. And you can fold it several times so that you have this strong cover over the AMED valve. Okay, so in this case, you don't have to get pericardial tissue or scleral tissue, and you can just glue this in place in a very nice, fast, elegant technique. So you want to focus your time more in getting that AMED valve tip into the right location and make it easy to seal the conjunctiva over the AMED valve. And lastly, we'd like to talk about amniotic membranes for the retina. So this is in the opposite side of the ocular surface disease. And we've been using amniotic membranes for a couple of years now for treating macular holes. So the success rate of macular hole surgery largely depends on the size of the hole at the time of the surgery and the etiology of the holes. For example, traumatic macular holes and myopic macular holes tend not to do as well as regular macular holes from aging. So retina surgeons have been using several adjunctive agents to try to improve the success rate of macular hole surgery, including using internal limiting membrane flaps, so flapping over the ILM over the macular hole, using autologous blood, transplanting autologous retina, and what's become very popular the past few years is using amniotic membrane patches. And this was first reported using fresh amniotic membrane or cryopreserved amniotic membranes, which again is not very accessible or has limited accessibility in many parts of the world. So here we present our first case of closure of the macular hole using an amniotic membrane. So, one of the principles of learning surgery is start off with an easy case. And so we picked this easy case with a lamellar macular hole. But you can see here that the roof of this macular hole is very thin, and we were afraid that if we did an ILM flap here, we might accidentally strip off or unroof this thin macular hole and convert it into a full thickness macular hole. So we decided just to put in a amniotic membrane graft. The amniotic membrane is translucent, so it's very hard to see when you put it inside the vitreous cavity. So we actually stain it with brilliant blue or trypan blue. We use gauge 25 vitrectomy cutter probes. So you hold this using a gauge 27 forceps with so that you have extra space to put in the macular hole, to put in the amniotic membrane. You put it on the surface of the fluid after completing the air fluid exchange, and then you use forceps to guide the amniotic membrane, very nicely seen here because it's stained in blue. You guide it over the macular hole to patch the macular hole, and then you can further do some more air fluid exchange, or you can put gas tamponade or oil tamponade. Okay, post-operatively, you can see the amniotic membrane covering the hole here, and post-operative OCT shows you the very nice placement of the amniotic membrane over the macular hole and the hole being essentially closed. Sometimes the amniotic membrane would fold over a few times. We call this the pigtail sign, telling you that the macular hole is in the correct place. So we've done this in more than 12 patients now, and we normally use it when we have large macular holes. Sometimes when we're trying to place an ILM flap over the macular hole, the ILM flap inadvertently comes off. So now we would, as a backup, place the amniotic membrane. Patients who had a previous macular hole surgery failure, so you're not sure about the status of the ILM, you can put a amniotic membrane patch instead, as well as patients with macular holes with low probability of closure, such as post-traumatic holes, as well as holes associated with pathologic myopia. Here in Asia, we see a lot of high myopes or pathologic myopes that have holes and develop retinal detachment. And these are some of the most challenging cases. How do you close the hole at the same time reattach the retina? Here you can see on the lower part a very large macular hole, almost the size of the, or actually about the size of the optic disc. So it's about 1.5 millimeters. We consider this a large hole. So what we do here is we apply the amniotic membrane over the macular hole, and then we put autologous blood over it. And then on top of this, you can put either silicone oil or PFO. And this seems to work. You can see here on the upper right, the amniotic membrane covering the hole, and that the hole has been closed. So in conclusion, dehydrated amniotic membranes demonstrate excellent biocompatibility, whether you put it on the ocular surface, whether you use it for glaucoma surgery, or whether you put it on the surface of the retina. It's very easy to use. It's readily available. You can transport it without any special temperature requirements. And for ocular surface treatments, it provides very good comfort for the patients, and it promotes healing of the ocular surface. And for pterygium surgery, it's associated with low recurrence rates, and it allows you to avoid damaging the conjunctiva when using a conjunctival autograft. So you don't have to do the autograft anymore. And for the retina, at the very least, it can help with the macular hole closure. And we're exploring ways to use it maybe for closing retinal tears in retinal detachments. So thank you very much for your kind attention. And I wish I could be in Morocco, but after the pandemic, I hope to visit you.
Great. Thank you, Dr. Harvey.
Good day, everyone. What a great meeting. I've learned so much. Let me share my screen. This is great to see a global approach to the ocular surface and so much commonality amongst all the presenters. I've learned a lot in great video, so thank you. So in terms of ocular surface reconstruction, look at the bottom right. I think most of us have a refrigerator that looks just like this, especially here in the US for the Super Bowl coming up in a few weeks. But there's a lot of ways to take care of the ocular surface and to reconstruct the ocular surface. Oftentimes, we won't do anything but just using good brand name artificial tears, sometimes preservative-free, to really enhance the emolliency of the ocular surface. When that sometimes fails or is not enough, we will use ocular steroids, especially the milder ones that can be used longer, and we use them for at least several weeks to a couple of months. Concomitantly, we will use an immunomodulator like cyclosporin. Here in the US, we have, now we have Restasis and we have Cequa, which is a higher dose or a higher concentration of cyclosporin, and the lifitegrast, known as Xiidra. Around the world, some of these medications may be available, maybe not, but we do like using immunomodulators and steroids and artificial tears to really promote and keep up with a good ocular surface. If that's not doing well enough, we will use punctal plugs to, again, enhance the ocular surface and keep some of the tear film behind and obstruct that tear duct. Oftentimes, though, when all these things work but don't work well enough, we will start looking at amniotic membrane transplants in office. Sometimes in the OR, there's significant keratectomy, conjunctival flaps, or conjunctival cut downs, as we saw in the wonderful previous videos. So what I like about going last is I'm repeating a lot of the things that I saw before, and hopefully this helps bring home the message. What are some of the ocular surface conditions where we'll use an amniotic membrane transplant? Well, for sure, corneal abrasions. People will have a paper cut at work or a corneal erosion. They want to get back to work. We like putting in a bandage contact lens. We like using AMT to help give it some nutrients and help promote that healing. And oftentimes these patients will go back within 1 or 2 days. We also like using non-steroidals here to help with the pain aspect. But usually the AMT does a wonderful job with the bandage contact lens. A persistent epithelial defect and Delin. We now see some pharmacologics out there, at least here in the US, looking at growth factors to help improve the ocular surface and neurotrophic keratopathy. A few of the professors before me spoke about filamentary keratopathy. And whereas we don't really use it for dry eye is a symptom, dry eye is also disease. We actually break it down more scientifically, at least in the US, the payers like the code filamentary keratopathy versus plain old dry eye when using AMT. All patients who have herpes, whatever age, whatever kind, we know have neurotrophic disease. And we will do a test to see if they have any kind of numbing of the cornea. I've stopped doing that because I know almost all patients, all diabetics have some form of foot disease and numbness of their foot. Same exact thing with herpes. So oftentimes these patients will have a recurrent corneal erosion, severe SPK, in filamentary keratopathy. Obviously, bacterial keratitis, we see this a lot, and it will lead to scarring and a lot of symptomatology. So whereas we may not use it if we're using fortifieds or antibiotics every hour or every half hour, once we get down to QID and the patient looks like they're getting better and they're headed for a good outcome with steroids to help mitigate the burden of the bacterial keratitis. Once we stop the steroids and go to artificial tears with a tapering of the antibiotic, we will for sure use an AMT. Corneal scars, as I mentioned before, you could do a keratectomy, it leads to some rawness of the ocular surface. And again, having the nutrients from the AMT does a wonderful job at smoothing out the surface, especially when you see some limbal cell deficiencies or even chemical burns. This list here is very brief, but again, in morning report, you want to talk about the first 5, 6, 7 things where we use it. And our last 500 AMTs, these were the most common diagnoses that we saw. Amniotic transplantations come a long way. We actually helped some of the earlier companies develop the in-office version and the compatibility of using it here in the ocular surface. It's very easy to use. There's different sizes, and Amniotic is wonderful. And thank you to Jay for all the wonderful work you do and being an innovator and a pioneer over the decades in AMT and ocular surface transplantation. But all amnios are good. We're seeing now a lot of entry in the market, but we like the ease of use for the dehydrated, easy storage, contact lens friendly, patient friendly, and staff friendly. Cost is always a concern if you have many choices. So now, usually here in the US, whereas before we only had a couple of choices, there's now a plethora of choices. And it seems like a lot of people here are using cost as a differentiating factor, as long as the technology is good. Techniques described this last couple of hours by all the wonderful speakers, we realized that by using AMT, we're able to go to this really awful looking desert to something kinder and gentler for the ocular surface. And as all of you continue taking care of these patients, you'll find that you may have to do this procedure more than once a year, maybe once every couple of years. But I think the ocular surface for sure has become a huge growth opportunity in our practices. We love being in the operating room, but we also love being in our offices taking care of patients with wonderful, unique, novel, and patient-centric procedures to help restore the anterior segment and the ocular surface. I want to thank the participants and also thank the wonderful organizers and Emin for inviting both myself and Dr. Pyle. Thank you.
Thank you very much. Wonderful presentation. I think now we are going to open the discussion. I think there is a lot of question here. I see on the screen that there is many questions. So we are going to start the discussion. Professor Obaz, are you still with us? Professeur Obaz, tu es toujours avec nous?
Oui, je suis là toujours. Présent.
Donc, ouais. Vous voulez bien ouvrir la discussion?
Oui. Les premières questions que je me pose, où on peut se procurer cette membrane amniotique? Là, à Rabat, par exemple.
Yeah. Tu as une réponse?
En général, la membrane amniotique est commercialisée au Maroc par une société Supraclinic. Donc, M. Fouad, qui est le directeur de la société, et qui va faire bientôt le tour du Maroc au niveau des CHU, au niveau des cliniques, pour présenter cette membrane.
D'accord.
Et on peut la commander même par téléphone.
Elle est importée. Une autre question, est-ce que nos laboratoires, nous avons plein de placentas, plein de femmes qui accouchent, pourquoi ne pas essayer de la fabriquer? Où sont nos laboratoires?
Alors, mon général, je pense que pour la membrane amniotique, ça passe absolument et obligatoirement par une banque des yeux. Et actuellement, il n'y a que la banque des yeux de Marrakech qui la produit. Et cette activité a été très perturbée par le Covid pour des raisons qu'on ne comprenons. Et donc, ce qui fait que pour les urgences, nous avons des difficultés à trouver la banque des yeux. C'est aussi pour moi une occasion de les remercier parce qu'ils font un travail extrêmement important. Ils nous procurent gratuitement les membranes amniotiques, mais ils ont été très perturbés par le Covid. Et c'est une bonne chose d'avoir d'autres options.
Il y a le problème de transport, aller la chercher, ça pose
oui,
un peu
de
problème de logistique. Mais est-ce que, c'est-à-dire au lieu de l'importer, c'est-à-dire on importe la technologie pour la fabriquer, pas nous, c'est les laboratoires. Les laboratoires qu'on a. C'est un appel aux laboratoires de faire un effort. Une autre question, est-ce que le pack qu'on obtient, parce que à un certain moment, je n'ai pas bien compris, est-ce qu'il y a, c'est-à-dire, j'ai vu, il y a deux formes de membrane, la ronde et la forme carrée. Est-ce qu'on obtient les deux ou une seule par pack?
Apparemment une seule. Moi, je n'ai pas d'expérience avec ça, mais apparemment, il y a une seule. Mais je pense si could you le fabricant, could you please give us more information about the available dehydrated membrane? There are two kind. We understand that there is two options. So we have to tell to the manufacturer to give us which one and what is the difference between the two.
Mr. Jai, if please, if you can speak about the product.
Sure.
Okay.
So there's two discs. One is called Amniotic Vision, which has a 2mm center hole. Both of them are 12 millimeters. So one is a full graft and one has a center hole. So
I did crack it.
they're actually used interchangeably. And then we have the grafts, and that's something else. But as far as the in-office application, we have the Amniotic C and we have the Amniotic Vision.
Okay. I have one question for the panel. I have one question for the panel. In your practice, did you found any difference between dehydrated amniotic membrane and the cryoid one, the one we take from the eye banks? In terms of efficiency, security, and other aspects?
Yeah, I think the great advantage of the dehydrated one is its ready availability. You don't need to have any special storage facilities. Secondly, it's very easy to handle, very easy to apply on the ocular surface, and as was shown by multiple speakers, by combining it with bandage contact lens, you can hold it in place, whereas with the fresh contact lenses, more often than not, you have to suture it in place, which takes some time and adds to the discomfort of the patient.
Right.
I just want to add the most important advantage of dry amniotic membrane is the fast recovery of the patients, because the natural amniotic membrane, you need to suture in a very nice way, because it is not like the dry, it's going to adhere directly on the surface, then put a contact lens. So in the normal amniotic membrane, you should spread it very well, take regular sutures, and this will make the recovery for the patient a long time with a lot of discomfort. Right. But the dry, it is early recovery, and you can do it even if you want to try it again after 1 month, you can do it again. But in the fresh, it is not an easy recovery for the patients.
Yeah, totally agree with you, Dr. Armia. Yeah. There is one other question. Many of these diseases you mentioned are chronic diseases. The question here, for example, for dry eye, severe dry eye, do you have to repeat the procedure many times? And if yes, how much? Every month, every 2 months? How do you deal with this situation, chronic disease situation?
That's a great question. Again, there's mild, moderate, severe, even chronic disease. So if they have bad filamentary keratopathy, if they have bad secondary recurrent corneal erosions, secondary issues with the ocular surface, they may have dystrophies and so forth. These kinds of patients may require it twice a year. And I've had one patient, we had to do it every 3 or 4 months, and it helped. If it didn't help, we would not repeat it. It's just that the disease was that bad. But for the majority of patients, I'd say we probably do it if they have bad filamentary keratopathy. As long as we're doing, immunomodulators, PRN use of steroids, reducing, some of the filaments and making them symptom-free. Oftentimes we'll do it once a year or once every 2 years. It depends. Every patient's so different. It's like glaucoma. Some require SLT once a year. Some require it once every 3 years. Some require it twice a year. It really depends on the nature of the disease.
Thank you. Thank you very much. One question about the contact lens. When do you remove it? At what time?
At least in our practice, we will do it, 10 days to 2 weeks. I really want a good uptake of the AMT. And again, with a bandage contact lens, as long as the patient has good hygiene, good finger hygiene, good hygiene in general, we will just do the bandage contact lens up to 2 weeks. And then I will oftentimes give moxifloxacin or any kind of generic fluoroquinolone, 2 times a day, just for protection.
Can I answer that question about the contact lens as well? So if you use a regular contact lens, we just take it off when the defect is healed. So I don't think you can give a time frame for that. If you use a contour contact lens, which is much wider and covers the limbus, we generally take that out a bit earlier because it's tighter on the eye. But the trade-off is it's more comfortable. And I just want to say one thing about the amniotic graft that's important. Dr. Harvey was mentioning there's a lot of pterygium in the Middle East, Asia, with all the UV exposure, as we do with certain patients that are ethically from the equator in our country. Another very good use of the amniotic membrane, for example, if you're having a lot of extensive pterygiums, bilateral pterygiums, large pterygiums, some of the surgeons still like conjunctival autografts. So they put the amniotic membrane where the pterygium is, for example, nasally or temporally. You can also use the amniotic membrane where you take the graft from. So if you have a large harvesting site, let's say you take a huge 5 by 10 millimeter graft from the superior bulbar conjunctiva, you can use the amniotic membrane as well. If you have extra, usually you do, you can also place it where the site of the graft is taken from. And in those patients, you'll see immediately there's less ptosis, less edema, and they're much more comfortable on day 1 through whatever. So that's just another use of the amniotic membrane, is to put it where the site of where the graft is harvested from, in addition to where the pterygium is excised from. I think it's another good use of the amniotic membrane.
Yeah.
I want to add one comment on the ocular surface disease with the dry amniotic membrane. And the dry amniotic membrane, it is not a treatment of ocular surface disease. It just decrease the discomfort of the patient, making the ocular surface regular, but you should treat the ocular surface disease properly.
Right.
So it is just a temporary, it is not a treatment for dry eye. So you should treat the dry eye well, or the ocular surface disease in the proper way, helped by putting the amniotic membrane to decrease the surface, the ocular surface irregularities that can make the tear film unstable in most of the time.
Good point.
The use of this membrane for ocular burns. Usually it's an emergency. Do you recommend to use it immediately after the burn, the chemical burns?
Dr. Harvey?
Yeah, so the first thing, of course, you have to wash out the chemicals using BSS, copious irrigation. We want to make sure the ocular surface is clean, so we'll put in antibiotics. And these patients come in, they are in severe pain. So by putting the amniotic membrane immediately with the bandage contact lens, you're able to lessen their pain and get them back to work more quickly.
Thank you.
For the chemical burns, because maybe in Egypt we have in the last decade we have a lot of accidents like this since 2010. So the most important in chemical burns that you should the lower fornix is the most insult part of the chemical burns. So sometimes you can see the injuries of the conjunctiva and the rest is okay, but the rest is not okay. So when you put the amniotic membrane, you should cover all the fornix of the lower lid. Very important, even if you find that there is part of the conjunctiva still present, but the stem cells is already in danger. So you should cover everything till the limbus of the cornea. Maybe use 1 or 2 or 3 parts. This is very important, because if you had one adhesion, you are going. This is failure of this.
Thank you very much, Dr.
In the Amniotic G, which is 150 microns, is usually the best you know, for dealing with these situations.
So thank you very much. We have one question here about corneal perforation. Do you use this kind of amniotic membrane in corneal perforation? Full corneal perforation, not only erosion.
If it's full corneal perforation, small, you should use the glue first.
Glue, yeah.
Glue first, and you make sure that there is no sealing, there is no fluid coming, and then you can cover it with the amniotic membrane. But the glue is the most important.
Yeah.